My name is Dr. Laura Belland. I am board certified in family medicine, geriatrics, and hospice and palliative medicine, and I am here today in support of SB 88. I'm here on my own accord. I am currently an inpatient palliative medicine consultant at a hospital in the Yale New Haven system. And this means that I am seeing terminally ill patients on a daily basis with a focus on trying to improve their quality of life. I am often asked by patients and families how I'm able to do the work that I do and how I can face death and dying every day. Nothing gives me greater satisfaction than to help ease a person's suffering, especially those who are in the last stages of their lives. And while I'm very proud of the work that I do and the work provided by hospice and palliative clinicians around the state, I know that it is imperfect care, and that for some patients, their suffering cannot be controlled, or if it can, it comes at a great cost to their quality of life. Take, for instance, a patient I had recently with stage 4 lung cancer who was struggling to breathe. The amount of medication needed to control her symptoms simultaneously sedated her to the point that she was no longer interactive with her friends or family or awake enough to enjoy food or drink. She passed away without her family being able to say goodbye. It's understanding that outsiders who aren't the family members of these patients or the clinicians caring for them would misunderstand what the actual dying process in the last 6 months may look like. What I don't understand is the baseless claims against aid in dying, such as the slippery slope argument, concerns that minority or vulnerable populations will be targeted, or access to care is limited, when none of these claims have any evidence backing them. I practice evidence-based medicine, and actually the evidence over the last 20 years is quite clear. It has been proven to be safe, and laws across the country have worked as they were intended. Perhaps most egregious is the constant conflation of aid in dying with suicide, despite multiple national organizations, including the American Association of Suicidology, rejecting the term assisted suicide. Suicide, as we conventionally know it in American society, is characterized most often by a person with a mental illness, done secretly and often compulsively and violently, and leaves loved ones traumatized and reeling, trying to understand why. Unfortunately, I know this all too well. My youngest sister died by suicide in 2018 while I was in fellowship training. Her death happened in the backseat of a parked car in an empty parking lot after she lied to her boyfriend that she was working. Her death was not like the deaths that have occurred with aid in dying, with the overwhelming majority occurring in the patient's home, planned ahead with loved ones all around, as Linda Bluestein described. In fact, data shows that the bereaved of aid in dying patients grieve similarly to the bereaved of other deaths, while suicide survivors, as we call ourselves, have higher rates of complicated grief, PTSD, and even higher rates.
Excuse me, Dr. Ballard, your time is almost up.
Thank you.
Thank you.
My mother, who was diagnosed with ALS 3 months after my sister died, understood the difference between aid in dying and suicide. If she, as a grieving mother, could understand the difference, I think the rest of society can too. My mother passed away peacefully in her sleep before her disease was in the final stages, but if she had lived, I would have supported her choice to use medical in dying. I have one thing to point out, that the American Medical Association's Council on Ethical and Judicial Affairs confirmed in 2019 that physicians who provide medical aid in dying are acting well within the Code of Ethics. Physicians may disagree, but whether they provide aid in dying or not, they are acting ethically and within the best interest of the patient. Additionally, AAHPM, my organization for hospice and palliative medicine, are actually neutral, and the American College of Family Physicians are in neutral, if not support.
Thank you. Thank you so much,
Dr. I have a lot to say about things that have been said here.
There are a lot of people with a lot of questions, I believe. So, Dr. Belland, thank you for your testimony. I'll start with Representative Foster.
Dr. Belland, thank you. Thank you, Mr. Chairman, or Dr. Chairman, we say today. Dr. Belland, thank you so much for joining us today. You brought up a really interesting, different perspective from many of the people who have testified today, saying that they had never met with someone who needed aid in dying, that they never suffered, they never had patients suffering at the end of their life, that palliative or hospice care was insufficient for. And I find it an interesting sort of juxtaposition that someone could advocate so passionately in the same field, in the same practice, as folks who say, like, this isn't a need, everything is mostly fine and handled within the system that we have. Do you have any way to reconcile what you view as those differences? I'm not sure if you've seen any of those testimonies that I'm referencing, but do you have any?
I've seen a few, and I implore everybody listening today to all the testimonies today to take everything with a grain of salt, including my testimony. I think there are some things that have been said that I've heard that are not true. So I want to talk about, the inpatient versus outpatient hospice dilemma, because hospice gets painted as this place where people can go, they can get palliatively sedated, which is not a thing. We don't do that regularly. And that people can get quite good symptom control, when the reality is most hospice is provided in the home. It is up to families and friends to take care of the patient. They do have 24-hour hotline they can call, but the nurse cannot come out immediately. There are a few cases where they can get 12 hours, 24 hours at home care, but that is rare. I am always counseling families before they go home with hospice that the care is going to fall on them and that they are going to have to be providing the medications. I'm not sure why some people say that palliative care and hospice can fill the gaps. When I have seen cases where I think, had I not stepped in as a clinician and administered high doses of medication, I think that person would have suffered.
So another sort of along that sort of line is that people's definitions of suffering seem to be subjective. And to me, it seems like a bill like Aid in Dying puts the onus of adding that subjective definition of what is dignity, what is comfort on the person experiencing pain. It's their choice, their decisions. And pain scales are subjective and flawed in certain ways. We have heard a lot of people reference the number 3 as the point in time where they're allowed to suffer up to 3, but what 3 is for different people might be different. And so I'm sort of curious about what you think about these folks who are like, well, that's an acceptable degree of suffering. We have defined like that amount is okay and acceptable. Have you sort of observed differences in what people are willing to tolerate from a pain scale perspective and what that means?
So yes, I have seen differences in people's ability to tolerate pain. I've seen differences in their desire to tolerate pain so that they can be more awake. There does come a point for some people where the amount of medication it's necessary to control their pain ends up making them foggy, ends up making them sleepy, tired. They may not want to do much. And so I have seen people who are willing to tolerate a bit more pain. I'm glad you brought up what suffering is, because another panelist said something about existential distress and seemed to dismiss it, when in reality, what we know in palliative care is that there is a subset of pain called total pain. And what it means is that the existential, the spiritual, the emotional pain of this person knowing that they are dying, that there's nothing they can do about it, and that it's going to happen, it actually accentuates any physical suffering or physical pain that they have. And if you don't treat the existential suffering, if you don't treat it with multidisciplinary effects, with such as a chaplain, a social worker, we know actually that it makes it much harder for the physician to just throw opioids at it or medications at it. And so to dismiss existential distress as just something like, oh, well, they don't want to lose their autonomy, is really not understanding the process of dying.
Thank you so much.
Thank you so much. Thank you, Representative Foster. Dr. Pettit.
Thank you, Mr. Chair. Thank you, Doctor, for your testimony. A two-parter. The subject frequently today has been the hospice and palliative care, and I'm wondering if you think there are significant changes, additions that need to be made under the current policies, regulations of the things that can be done and can't be done that would improve care there, number one. And number two, what I asked Professor Rizzolo, in many of the situations we've heard about, people with ALS, swallowing problems, et cetera, in terms of administration of a dose in Aid in Dying, how would you approach that issue?
So going with that one first, we don't have a solution for ALS. That's just where we are. You may have seen there was an op-ed recently in the newspaper by a woman with ALS commenting that she's going to have to end her life early before she loses her ability to administer her own medication. So I don't have an answer for that. My mom, that's what she had. So that is what it is. So this bill isn't going to be able to help people with ALS in the last 6 months of their lives unless it's bulbar. Bulbar is where it starts in the throat first and they aren't able to breathe. If that person decides they want to take off their breathing machine, they will die in 6 months. They may still be able to give it to themselves. Otherwise, we can't. I think there's so much that could be changed about hospice and palliative care. I think the number of organizations needs to increase, the number of hours that the organizations are willing to give, and this all comes down to Medicare. Medicare only pays a certain amount per day, and the hospice then has to take that money and distribute it as it can. And so the reason that some hospices don't provide things like radiation oncology is because it's too expensive for them, and they decide that's one thing they're just not going to be able to give. So if we were able to get Medicare to actually step up and give more dollars, give more monies for hospice care, I think we would have such a much better system. Would we be able to fill the gap for patients who are symptomatic, who still wish to take medical aid in dying? No. And I think that that is because for a certain number of people, and it's a small number of people, a certain number of people, they get to a point where they have peace with their life. They have peace knowing that the disease process is taking their life. They have peace knowing that it is time for them to go and that they can do it in a controlled manner and it's in their control. And on that basis, I wanted to bring up a couple of things. There's been a lot of talk about the medications that are given. So I want to dispel a couple of myths. I have a good friend who practices medical aid in dying in California. And they actually, a lot of the medical aid in dying doctors actually get together over whatever, email, whatever, and they share ideas. They actually share what works. They share the number of people, when they die, how many hours. In her practice, in the practice of her colleagues, 85% of patients die within 2 hours. Only less than 3% are alive more than 5 hours, and only one patient was alive up to 10 hours. It is a mixture of 4 medications right now that most people use, something called digoxin, which is a heart medication. They use a tricyclic antidepressant. They use 2 grams of diazepam. If you think about that, we usually talk about milligrams of diazepam, 2 grams, and 15 grams of morphine. It ends up making a slurry. So there's no way a person would be able to put it in some apple juice, hand it to their mom and say, drink up, mom, it's just apple juice. It tastes very differently. It makes the consistency very different. For anybody who has GI issues, let's say that they have slow motility and they may not process it very well, the doctor gives them medications beforehand to make sure that they're not going to vomit it up. And there doesn't seem to be any issues. They're not vomiting all over themselves and aspirating. And if there is any concern, you can give it rectally.
Mr. Chair, if I could have one follow-up.
Yes, please.
Doctor, in the current environment with the regulations for Medicare and people that follow it, are you able to administer intravenous a morphine drip at home, or is that clearly not allowable under the current regulations?
Under most hospices, you can't do it. So I know the lady who was in charge of the hospices mentioned subcutaneous. Subcutaneous is the best that I've ever seen. The issue with subcutaneous is you can't go up above a certain rate. It literally just can't get into the skin and do above a certain rate. And the other thing is it's not as fast acting. It takes up to 30 minutes to actually take effect. So that's 30 minutes while you're waiting for your loved one to stop breathing so heavily or have you. So most cases, if they need intravenous, they have to go to inpatient. The problem with inpatient is Medicare limits the number of days they're allowed to stay there. And you have to be actively titrating the medications in order to qualify. So this becomes an issue when people stop being able to swallow and the subcutaneous may not be enough or patches may not be enough. What do you do with them? I am stuck in a lot of cases. I can't tell you how many cases I have here in the hospital that when they're ready for discharge, their loved ones cannot take them home. They are not able to care for them in what they need. They can't turn them every 2 to 4 hours to avoid pressure sores. They have to work. They can't do FMLA for whatever reason. And so I am stuck with the care coordinators trying to find a place for these people to go. And luckily, Branford, run by Connecticut Hospice, is a wonderful organization, and Yale has a contract with them that if we think a person will die within 30 days, they're willing to take them. Yale will pay for the bed. But if they live more than 30 days and they're not meeting hospice criteria, they have to find a different place to go to.
Thank you, Doctor. Thank you, Mr. Chair.
Thank you, Representative Pettit, Dr. Pettit. And next is Representative Berger-Giavalo. Please go ahead.
Thank you once again. And thank you so much, Doctor. I just have one question for you on the Council of Ethical and Judicial Affairs statement. What does that mean to you? And has that impacted your views, specifically your views on this issue?
So as you all probably know, medicine is not always with the times. Medicine often lags behind society. It has been hard for medicine to get on board with transgender patients. We are not the people to look towards for what society may want. So yes, it does help me when I hear things like this, but I also actually don't look up to a lot of these organizations. And the reason is because, similar to some of the testimonies I've heard here, there are a lot of people who are not on the ground. They are not treating patients. They are in offices, or they are radiologists, as one of our past panelists was. I'm not sure when they've been seeing patients on the ground and actually treating them. And so when they put out statements, yes, it can help, but if they were to ever say anything else, I don't look to it as my guiding light. I am constantly evaluating what's happening on the ground. I'm talking to my colleagues, what they're seeing, looking at the evidence, like I said, with all the other states that already have it in practice without difficulty there. That's what I look to.
And I appreciate that you clearly have a curiosity about what is going on, not just in your own space, your own space, but also elsewhere, and talking to colleagues that are in other states and administering this. And so thank you for sharing all of that and from such a broad perspective. Very much appreciate it.
Thank you, Representative. So I had a couple of questions as well. First, I wanted to just say that thank you for the work that you're doing. It takes a lot of special gifts an individual has to do that. And I can tell that you do it with a lot of empathy and care. So I wanted to thank you for that work. And it takes a lot out of an individual when you're living in that space, but at the same time, you can give so much care to a patient, and that's rewarding in that situation. When you cannot do anything, you can at least make them comfortable. I wanted to clarify a couple of things. One is there was a comment that was made that these medicines are not FDA approved. And as I look at the medicines, I think they are all FDA approved. So that's more of a yes and no question. I wanted to clarify that. I know that they are, but I want you to be able to say that. Are they FDA approved?
I almost laughed when this was brought up. I have to be very honest. The number of times that people take non-FDA approved medications on a daily basis, it's happening all the time. And that's because the FDA is a very arduous, they have a very arduous process, and they recognize that there are lots of medications that can be taken for off-label purposes that are just fine. So yes, all of these medications are FDA approved in themselves. Of course, the FDA has not looked at this cocktail and approved the cocktail.
Okay. The other question I wanted to ask you was, there's almost a sense of dichotomy that I'm sensing in the legislators right now. One is that let's fix palliative and hospice, and then we won't have to worry about this. And I don't think it has to be dichotomous. We have to improve that. But that doesn't take away from the need of this specific need for some of the patients that require aid in dying.
Yes. So actually, if you talk to some of the physicians that are actually administering aid in dying, they all recommend that their patients do go into hospice. So it is not this case where a person comes into an office and it says, hey, I have a terminal disease, I want this medication. And the doctor just says, okay, it is that doesn't exist. What exists is we're going to start with hospice, we're going to start with palliative care, we're going to make sure you're not depressed. If then, despite all those things, that person is still requesting it, which is why the safeguards exist, then that is where it's not that palliative care failed. It's that the person is desiring something that palliative care cannot provide or that hospice cannot provide. And I wanted to make a comment about the safeguards. There are safeguards everywhere in medicine. Somebody mentioned that because there are safeguards, this must mean this is a really dangerous thing. You have to go through an entire checklist when you go into the OR. Atul Gawande wrote an entire book about this because people were cutting off the wrong limbs. Yes, there are dangerous things in medicine and the risks are real. And that's why we have safeguards to protect against cutting off the wrong limb or allowing a person with mental illness to get medical aid in dying. And sorry, one more thing, but the doctors about, the people who say in Yale who said, yes, I would want to do it. But when it got down to, would you do it? I would question, well, what doctors are we talking to? Orthopedists, plastic surgeons? There are many doctors who will never, ever be in a position to do something like this. So I wouldn't blame them. Then they shouldn't be offering it. It should only be people who are going to commit to being experienced, knowledgeable, study, understand what's happening. And that's going to be a very small subset of physicians. I'm not surprised by that.
Thank you so much. I think in my line of questioning, I was trying to allude to that very fact earlier as well. I have another representative who has a question. Representative Carpino, please go ahead.
Thank you, Chairman. And Dr. Belland, thank you very much. As a non-medical provider, I've appreciated your testimony. So please take this question for what it is. It is a layperson asking. Knowing that this is such a specialized position for a medical provider to be in. And I agree, if this bill passes, I wouldn't want my orthopedic, as wonderful a fellow as he might be, involved in a decision like this for anybody. With that said, how much training, experience, specialized training, education should a provider that's going to have the ability to write such a prescription of magnitude have before they're given that right?
So I think we are in uncharted territory. As I imagine Oregon was and Washington was, I would be very interested to see how those physicians started out. I am not going to say that every physician who needs to do this needs to do a palliative care and hospice fellowship. The friend that I mentioned who practices medical aid in dying in California is not fellowship trained. She actually trained to do medical aid in dying under one of the more famous experienced doctors in California. So perhaps that needs to be written into the legislature. I would be in favor of that. I agree. I think there's got to be some sort of oversight and training so that when something may not go right or something unanticipated, the physician is not caught and doesn't know what to do.